Most people assume that when a surgeon suggests an operation, it has to be the correct path forward. The physician understands best. The hospital possesses all the necessary equipment. The consent forms are prepared. Just put your signature down. I once accepted that belief myself until I began keeping track. Tracking the patients who arrived for routine procedures and emerged permanently altered. Not improved, altered. A man who entered the hospital dealing with back pain and departed completely unable to walk. A woman who made it through open heart surgery, yet forfeited half a year of her life to complications no one had cautioned her about beforehand. Here's the reality nobody discloses. The more years your body accumulates, the harder it must struggle just to endure an operation. Not the illness itself, the procedure. My name is Dr. Narita, and today I'm going to reveal the truth about 5 operations carrying serious concealed dangers for those over 60 years old. Before we dive in, there's one brief point worth mentioning because it's relevant to everything ahead. If you're past 60, or you sense that milestone approaching, and what you genuinely desire is to live longer, more vigorously, and healthier while keeping the freedom to make your own decisions for years ahead, then grant me just 10 seconds. I gathered everything I share with my own patients and compiled it into a single, straightforward plan. It has already assisted thousands in living their finest years past 60. You'll find the link right there on your screen. No need to jot anything down. Simply glance at it once we've wrapped up here. And if this video benefits you today, do me a small favor. Hit subscribe, drop a like, and leave a comment. It helps me connect with more people who genuinely need this knowledge. Now, let me pose a question. If you took a brand new vehicle and another one with 200,000 miles logged, then subjected both to an identical stress test, would you anticipate matching outcomes? Certainly not. Yet for decades, medicine approached a 70-year-old body exactly like it treated a 40-year-old one. Identical surgical protocols, identical recovery expectations, identical time frames. That's starting to shift, though not quickly enough. Here's what genuinely occurs inside an aging body under general anesthesia. The heart must labor considerably harder. The lungs require more time to clear the anesthetic. The kidneys slow down when processing medications. And the brain, this is the part that catches most people off guard. The brain can become temporarily muddled in ways that might persist for weeks or even months. Physicians have a term for this: post-operative cognitive dysfunction. Among patients beyond 70, this occurs far more frequently than most realize. Now, I want to make something entirely clear. Age alone isn't grounds to avoid surgery. I've operated on 80-year-old patients who bounced back quicker than certain people in their 50s. Age is merely a figure. Frailty is not. Frailty is an actual clinical term. It signifies that the body's reserves have dropped beneath a critical point. Roughly 40% of people past 75 display signs of frailty. That figure rises to nearly 60% among those beyond 85. So here's the genuine question. It isn't whether someone can endure the operation, it's whether they can endure the recovery. Those represent 2 entirely different matters, and that difference is about to become tremendously significant. Surgery number 1, open heart surgery in frail patients. Coronary artery bypass grafting, or CABG, ranks among the most frequently performed major operations on older adults. The idea is straightforward. Your arteries get blocked. We redirect the blood flow, and for the appropriate patient, the outcomes can be remarkable. But here's what the pamphlet never reveals. Open heart surgery demands halting your heart entirely. We connect you to a heart-lung bypass machine, a device that momentarily handles the function of your heart and lungs while we work. For a robust 60-year-old, that's typically manageable. For a 78-year-old dealing with kidney disease, mild diabetes, and early cognitive decline, that bypass machine imposes enormous strain on nearly every organ simultaneously. Research indicates that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended ventilator dependence. And here's something that halts many people mid-thought. As many as 15% of high-risk elderly patients don't survive the initial 30 days following this surgery. So what's the alternative? Nowadays, in numerous cases, there is one. It's called TAVR, transcatheter aortic valve replacement. This catheter-based technique doesn't require stopping the heart or opening the chest. It's less intense than conventional surgery, yet far more merciful toward a body that needs gentleness, not another fight. Does this mean you should decline heart surgery? Absolutely not. It simply means you should pose one crucial question to your surgeon. Am I a candidate for a less invasive method? That single question could transform everything. Surgery number 2, aggressive spinal surgery. Back pain throughout your 60s and 70s is nearly universal. I honestly can't name a single patient past 70 who hasn't mentioned back pain at some point, and the treatment being suggested increasingly often is spinal surgery, spinal fusions, multi-level decompressions, metal hardware placed throughout the spine. Now I need you to absorb this clearly. Certain spinal surgeries are genuinely essential. There's no dispute about that. If the spinal cord is being actively squeezed, causing loss of bladder control or paralysis, immediate surgery is critical. But elective spinal fusion for chronic back pain in an elderly patient, the evidence is truly troubling. A significant study published in the journal Spine discovered that among patients past 65, complex spinal fusion carried a complication rate surpassing 40%. 40%, and the most frequent complications were far from trivial. Blood clots, infections, hardware breakdown, and something called adjacent segment disease, where the vertebrae above and below the fusion begin breaking down because the spine's mechanics have been permanently changed. The hardware holds one section stiff, while the remainder of the spine absorbs the consequences. And here's what troubles me most: pain relief. Research consistently demonstrates that for numerous elderly patients with degenerative spinal disease, aggressive surgery delivers no superior long-term pain relief compared to physical therapy paired with targeted injections. No better outcomes, but dramatically elevated risk. I once had a colleague, a gifted spine surgeon, say something I'll never forget. Sometimes the finest operation is the one you never carry out. I reflect on those words frequently. Have you been told surgery was your sole option for back pain? Share it in the comments. I genuinely want to know how many of you have heard those precise words. Surgery number 3, major cancer resections. This is arguably the toughest to address because when someone hears the word cancer, the reaction is instant and overpowering. Cut it out, remove it, eliminate it. I completely grasp that response. I'd likely feel identical myself. But here's what over 20 years in surgery have taught me. The objective of treatment isn't merely removing the tumor. The objective is granting the patient more years of quality life. And occasionally, not always, but occasionally, major surgery in a frail elderly patient achieves precisely the opposite. Let me offer a genuine example. Pancreatic cancer surgery, the Whipple procedure, ranks among the most intricate operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. The surgery itself typically spans 6 to 10 hours. In younger, healthier patients, it can truly save lives. But in an 80-year-old with heart disease and diminished kidney function, the surgery may be technically successful, the tumor gets removed, yet the patient still dies within weeks, not from the cancer but from complications of the operation itself. This is termed futile surgery, and it's more widespread than many are willing to acknowledge. A landmark study from the American College of Surgeons discovered that nearly 1 in 5 elderly cancer patients who underwent tumor resection experienced what's called failure to rescue. In other words, a complication arose that the weakened body simply couldn't withstand. So what's worth pursuing? Ask your oncologist this question directly. If we don't operate, what would watchful waiting, radiation therapy, or targeted therapy resemble for someone my age and with my overall health situation? That single question unlocks a door that many patients never even realize exists. And sometimes what's behind that door is genuinely the superior option. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements rank among the most successful surgeries ever created. I state that without reservation. For the appropriate patient, a new hip can genuinely revolutionize quality of life. People progress from barely walking to playing with grandchildren again. It's extraordinary. But this is where matters grow more complicated for older adults. The word elective signifies the surgery is scheduled. It isn't an emergency. You have time to reflect, you have time to prepare, and most crucially, you have time to determine whether this is truly the right moment for your particular body. Because here's what the statistics reveal. Among patients past 75 who have 3 or more serious medical conditions, such as heart disease, diabetes, chronic kidney disease, or obesity, elective joint replacement carries a notably higher risk of perioperative complications. The greatest hazard is blood clots. Deep vein thrombosis, or DVT, happens when blood clots develop in the legs. Those clots can migrate to the lungs, triggering a pulmonary embolism, a life-threatening condition. In elderly patients with poor circulation, this risk runs considerably higher than in younger individuals. Then factor in post-operative pneumonia caused by extended bed rest. Add hospital-acquired infections. Suddenly, the situation becomes far more complex. I want to be very precise here because I don't want to frighten anyone away from a surgery that could genuinely enhance their life. The question isn't, should I ever undergo a joint replacement? The real question is my body currently in the best possible condition? Optimizing your blood pressure, blood sugar, body weight, and cardiovascular health before an elective operation can dramatically lower the risk of complications. Some hospitals now mandate that high-risk elderly patients complete a formal prehabilitation program before they'll even schedule elective joint replacement surgery. And honestly, that's exactly the right approach. Has your physician ever discussed prehabilitation with you before a planned surgery? Most people have never even heard the term, and they absolutely should. Surgery number 5, emergency abdominal surgery. Now, I need to pause here momentarily because this one differs from the others. You don't select emergency surgery. Emergency surgery selects you. A perforated bowel, a ruptured appendix, internal bleeding. These circumstances don't wait for a calm conversation in a doctor's office. But here's why this belongs on the list. Understanding the risks beforehand, before the emergency ever unfolds, can completely transform how families make decisions during those terrifying moments. Emergency abdominal surgery in patients past 75 carries one of the highest mortality rates across all of surgery. We're discussing 30 to 50% in the most severe instances, not because surgeons lack skill, but because an elderly body confronting sudden trauma is battling too many fronts simultaneously. The liver, the kidneys, the heart, the lungs, every major organ faces enormous strain at once, and the inflammatory response that a younger body typically manages within a few days can spiral uncontrollably in an older body into a condition known as systemic inflammatory response syndrome, SIRS. When multiple organs begin failing one after another, it's every bit as grave as it sounds. So what can you actually accomplish with this information? 2 things. First, never dismiss abdominal symptoms. Persistent abdominal pain, bloating, changes in bowel habits. If you're past 60, these symptoms warrant prompt medical evaluation. Catching problems early frequently means addressing them before they escalate into surgical emergencies. That single habit can transform everything. Second, have the conversation with your family now, not in a hospital corridor at midnight. Now. What are your wishes if emergency surgery becomes the sole available option? What level of quality of life matters most to you? These conversations aren't grim. They're among the most caring things you can do for the people who may one day stand in that hospital hallway, making impossible decisions on your behalf. All right, we've covered 5 surgeries. Now let's discuss what you should actually do with this knowledge, because information without action produces nothing but anxiety. And that's the last thing I want for you. Before any major surgery, whether planned or recommended, every patient past 60 should ask 4 essential questions. Write these down. Question number 1. What happens if I decide against this surgery? A good surgeon will respond honestly. If the answer indicates nothing urgent is likely to shift over the coming 6 to 12 months, then you possess something incredibly precious: time. Time to reflect, time to seek a second opinion, time to improve your health before finalizing a decision. Question number 2, is there a less invasive alternative? Medicine has transformed tremendously over the past 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions. Numerous treatments that didn't even exist a decade ago are now available in most major hospitals. Question number 3, what will recovery realistically resemble for someone my age and with my health profile? Not the average patient. You, your heart, your kidneys, your current medications, your overall physical state, your living situation. The response should be personalized, not generic. Question number 4, and this is the one almost nobody poses. What is your personal complication rate for this procedure in patients past 70? Surgeons monitor these figures. They know their outcomes. A confident and honest surgeon will inform you. And if they appear uncomfortable answering that question, that alone is valuable information. Now, I want to share something very few patients ever learn, even though it may boost your chances of a successful recovery more than nearly anything that actually happens inside the operating room. If you decide surgery truly is the right choice, what you do during the 2 to 4 weeks before entering that hospital matters enormously. Surgeons spend years perfecting the operation itself. Almost nobody spends 2 weeks preparing the body that has to survive it. Let's change that. The first step is something we touched on earlier: prehabilitation. Think of it as training for a major athletic event because that's precisely what surgery represents. Your body is about to run a marathon while you're unconscious. So during the weeks beforehand, your goal is building reserve. Consume more protein. Your body relies on protein to rebuild damaged tissue. Yet many people past 60 quietly fail to eat enough of it. Walk every single day, even if it's merely around the block. The stronger your legs and lungs are before surgery, the sooner you'll manage to get out of bed afterward. And getting out of bed early ranks among the best ways to prevent the blood clots and pneumonia we discussed earlier. If you smoke, even quitting just 2 weeks before surgery measurably reduces your risk of wound complications and lung problems. Just 2 weeks, that's all it takes. I've personally witnessed prehabilitation transform a patient deemed high risk into someone whose surgery became relatively routine, and it costs nothing beyond commitment and effort. The second step involves a conversation almost nobody has: the conversation with your anesthesiologist. Remember the brain fog I mentioned earlier? Postoperative cognitive dysfunction. There are practical measures that can lower the odds of developing it. Request a preoperative consultation with your anesthesiologist. Bring a complete list of every medication and every dietary supplement you take. And I mean every single one, including fish oil, including herbal sleep aids, because some interact with anesthesia in ways that surprise both patients and families. Ask whether a regional or spinal anesthetic, where only the surgical area gets numbed instead of placing your entire brain under general anesthesia, is an option for your procedure. For many hip and knee surgeries, it is. And for an aging brain, it's often the gentler choice. Finally, here's one small detail that sounds almost too simple to matter, but it does. If you wear hearing aids or glasses, ask to keep them with you until the very moment you go under anesthesia, and ask to have them returned as soon as you wake up. Patients who can see and hear clearly the instant they wake from surgery become confused far less often. The research on hospital delirium is very clear about this, and it costs nothing. The third piece is the one almost everyone overlooks until they're actually living through it: your recovery setup at home. Arrange your support before surgery, not afterward. Who will drive you home? Who will stay with you during those initial few nights? Where will you sleep? The fewer stairs you must climb during the first week, the better. Remove loose rugs and electrical cords that could cause tripping. Pick up all your prescriptions beforehand so you aren't sending an exhausted family member to the pharmacy at 9 o'clock at night. The first 72 hours after returning home often establish the tone for your entire recovery. And a body that isn't grappling with a fall or a missed medication heals considerably faster. Also, watch carefully for warning signs during those initial days: sudden confusion, a fever, a calf that becomes swollen, warm, or painful. If any of those occur, call your doctor immediately. Don't wait. The fourth piece is this: please obtain a second opinion. I know it can feel awkward. Many people worry they'll offend their surgeon. Let me put that concern to rest immediately. A good surgeon expects you to seek a second opinion. A great surgeon welcomes it, because that's precisely what they'd want for their own mother. Bring your imaging studies and medical records so the second surgeon reviews the exact same information. And if two qualified surgeons evaluate the same patient, examine the same scans, and arrive at different recommendations, that isn't a problem. That's valuable information. It's exactly the kind of information you deserve before anyone ever picks up a scalpel. None of this concerns fear. It concerns entering surgery prepared instead of merely hopeful. A patient who arrives strong, informed, and organized represents a fundamentally different surgical risk from one who arrives frightened and unprepared, even when both undergo the identical operation. You have far more control over which of those two patients you become than anyone has probably ever told you. There's one more thing I need to share with you, and it may be the most valuable advice of all, because it concerns learning how to interpret the recommendation itself. Over the years, I've learned that